still are being trained in the way whereby you're asked to check that you remove the wax, that you remove with loops with an otoscope, which defies logic really. Why wouldn't you be able to visualize whether you remove the wax with the head loops? Why would you need to revert to an otoscope to check that you've cleaned the earwax? And I think that sums it up with loops. It's just, for me, I just don't think the magnification's there. I think if the wax is quite lateral, so in the outer cartilaginous portion, fair enough, it may be suffice. But quite often when you're in clinics, it's only a small percentage of patients that I see that have wax laterally. Most patients have earwax that's beyond the second bend. And it's quite problematic for them. And so you can just see, now when I use with loops, I found because the instrument goes straight through the centre of the speculum, you do get a bit of a distorted view of the instrument. But when developing the wax scope, I was trying to incorporate some of the key benefits of an endoscope. And I think with an endoscope, it's the view you get with the instrument, it's always in focus, because that's the instrument's so crucial, being able to see that clearly, because you are, of course, inside someone's ear, and you don't want to be causing trauma by bumping into the canal walls, or worse still, the tympanic membrane. And we've got a lateral slit. It's also Tomarkin style speculum, so there's a slit at the roof of the speculum, which you use to insert the instrument in. So it's coming from a higher angle of incident. And that's what typically you do with an endoscope. When you're inserting the instrument with an endoscope, the ear canal, of course, is more oval shape. So if you're having the instrument side by side, you're limiting the movement available with both the instrument and endoscope in the ear. Therefore, with an endoscope, you're using the oval shape, that the height of the ear canal is obviously greater than the width. So you have the endoscope positioned more at the bottom of the ear canal, and the endoscope the bottom of the ear canal and the instrument over the top. And that helps also not only with manoeuvrability in the ear, but also the view provided of the instrument. It's not coming in a straight line behind the lens, the magnifying lens of the microscope or the head loops or the wax scope in this case. And this wax is quite medially impacted. What's making it a bit more problematic is these hairs. When you have matted hairs, you lose the suction grip a bit. I am going to use forceps in a minute, I believe, to remove some of these hairs. And if you stay tuned for the patient's right ear, it's probably a lot more hairs in there. Now, you can just see this wax coming off the eardrum. You can just see, so this is the patient's left ear, so you can see the inferior, posterior portion of the eardrum there. And so this wax is lodged beyond the isthmus. So the isthmus is a narrowing about 0.5 centimetre away from the eardrums, where the ear canal narrows and it widens again. And that narrowing and widening typically creates two recesses. One inferiorly, so the inferior recess, which is like a trench, like a trench or a basin, a dip, if you like, at the bottom of the ear canal near the eardrum, and an anterior recess, so to the front portion of the ear canal. So in the case of the left ear, we're talking on the left-hand side of the ear canal, and quite often you can get wax trapped in the inferior and anterior recess. Now, the reason for this patient's wax buildup, they do have to have it regularly cleaned. They're a hearing aid wearer, and they feel it's compressing the wax further in, and the telltale signs are acoustic feedback, obviously. So we're almost there now, and one of the things with the wax scope, you can't compare any imaging device, whether it's a microscope or a wax scope or head loops or anything else in the market, to an endoscope. An endoscope is just unrivaled in terms of the wide field of view. And it's taken me a while to get back in the microscopic mode of removing wax, because I am trained in obviously an ENT microscope. I've got a couple at the clinic, and it does take a while to readjust, especially after using an endoscope. But the reason for developing the wax scope is, unfortunately, not everyone feels comfortable using an endoscope. It just requires a high skill level, and so does an ENT microscope. I was talking to an ENT consultant just the other day, Chris Colson, and we're discussing the ENT microscope, and he was saying that it is the difficult thing to train people on. He's known people that have used it for years, registrars and nurses, and they can sometimes struggle with the operation of a microscope. And so the wax scope was a complementary device. It's an alternative to the endoscope, the eye clear scope, and I feel it's the next best alternative. Everyone had their own view, but I think the optics speak for themselves, really. So you can see there's loads of hairs there. I do get a few out in a moment, but otherwise the TM's intact. You can even see the blood vessels on the handle of malleus and under superior portion. So I've just put the forceps in. And that's another thing about the wax scope. You can use all ENT microscopes. You're not just limited to microsuction. So I'm really pleased with that. I'm just going to leave the hairs there. They're non-problematic. Well, I think I went back for a couple more, actually. There we are. And I think we're going to move on to the patient's right ear at the moment. So you can see the handle of malleus, you can see the short process of the malleus there. So same patient, and this is their right ear, and again, you can see the wax is quite dark. They had been using some drops prior to attending. They attended with their significant other, and it's the first time they came to the clinic. And in fact, they left a lovely review today. Well, they emailed a lovely review, so I'll have to upload that. So the right side, it's actually a bit easier to remove. And I was working at the roof of the ear canal there, and I'm just going to the core, the middle. You can just see that clarity. You can almost see the wax reflecting back off the Zollner suction probe. Now, you can see there's a big bunch of hairs here, so I think I'm going to revert to the forceps in a moment, just to remove some of these, just to get a better suction grip. The reason for these hairs, they're loose hairs. The patient does trim their tragal hairs, and no doubt they are flying loose into the ear. So I just recommended them to position some cotton wool just at the entrance of the ear canal, just to seal the entrance, preventing the hairs to enter when they're trimming their hairs. So I think this is the moment I'm possibly going to use the forceps, which we'll see. So I'm just visualising. I'm going to use stats in a moment. So I'm just going more to the more inferiorly now, to the base of the ear canal, just trying to detach this from the base and loosen it. But you can see there's just too many hairs there. It's preventing me from getting a suction grip. And where we are now, this is all beyond the second bend. You can just see the cartilage to the right, and that's the juncture, the osseo-cartilaginous juncture we're at. So just back to the roof. I'm trying to bring this wax down and under, and you can see all that keratin there as well. So as you can see, there's some to the right where I'm going now. There's some dead skin. I've just got a bundle of hairs now. Almost like a fair ball in there. So I'm going to go back in. I'm pretty sure this is the point where I use the forceps. You can just see all these hairs are all stained as well. So again, this is the value of the wax scope. You can use all instruments. Remove the big bundle there. I'm going to go back and get some more. So although it's not removing the wax, it's just helping the procedure moving forward. So just widening that. And I'm using the 5mm microjaw forceps here. Okay, so I think you can see those hairs. There's a few left at the bottom, but the majority have been removed, and instantly it just helps with me obtaining a suction grip. And you can see that wax plug came out in a nice large piece. So I'm just mopping up there. There's still a bit of wax just around the edge. Now, in terms of removing this is probably not going to improve the patient's symptoms, but patient they have poor mobility, so the longer we can leave it in between appointments would be better. So I went to get it. Also a hearing aid wearer, so I don't want the tip of the meatal tip, the soundboard, to get blocked with the wax. So lovely view of the eardrum. You see you can actually see the radial muscles there. You get the light reflex, short process of malleus. I'm very pleased with that. You can see the annulus on the right, good light reflex, and patient symptoms are been alleviated. If you're interested in the wax scope, it's due to be launched early autumn 2022. We're just waiting for all the manufacturing phase now. But if you're interested, please email info@clearwax.co.uk.